Sangvai. I'm a family doctor from Durham, and I'm also president of the North Carolina Medical Society. Thank you for the opportunity to speak today about Medicaid reform. As many of us know, implementing reform to ensure Medicaid works efficiently and accomplishes its goal is necessary and comes at a critical time in North Carolina. The healthcare system, as we've all heard, is undergoing a much-needed change in this direction. In fact, by many measures, Medicaid is the only payer that has not moved towards a value-driven system. We believe adoption of value-driven principles will help accomplish the dual goals of budget predictability and a sustainable delivery model that is accountable for the patient's complete health care. Deciding what to do, of course, is the hard part. The current fee-for-service system has created what some have called silos of medical care, where volume is treasured over value. However, we are fortunate that in the patient-centered, physician-led changes occurring right now in the state of North Carolina, that there are indeed systems in place that are putting value over volume. These changes require all providers to focus on the patient's full set of medical needs, formulate efficient ways to take care of them, and simultaneously break down these current silos. We've heard many times today, as well as yesterday, that there are a number of accountable care organizations already in North Carolina aimed at doing just that. Reforms focused on incentivizing the ACOs to improve the health of their patient population while controlling costs is a powerful motivator for the different types of providers to work together. In these arrangements, value is achieved by ensuring and improving quality and eliminating wasteful spending. Data coming from the new physician-led ACOs are already showing positive results. For example, Coastal Carolina Healthcare recently shared quality results of 25 to 30% savings for their Medicare, Medicaid dual eligible patients. Now, this is probably a good time to make the point that if you carve out big chunks of care and allow them to be isolated or treat them separately, you lose the alignment and you lose the ability to have consistent incentives. Incentive structure is destroyed, and the potential for savings along with it. The whole patient goal is an important one. As we all know, change is not easy, and we encourage you to look at the infrastructure that's been put in place to implement new value-driven systems for the private sector and Medicare. There are federal standards for accountable care organizations for the payment systems that derive efficient care. We believe most of these will be very helpful to the department as it formulates its plan and recommendations to the General Assembly. More specifically, we believe you should consider a process to permit these Medicare-approved ACOs to become Medicaid-approved ACOs. Right now, there are Medicare-approved ACOs in the same counties as approximately 50% of North Carolina's population. With the addition of additional qualified ACOs, a large majority of the Medicaid recipients could be in value-driven arrangements in less time than it would take to implement a traditional managed care program. We do not think that driving the state into regions for reform purposes is necessary or helpful either. The current Medicare ACOs do not require regions in order to get started. In fact, we are concerned that regions will undermine the natural development of provider-patient relationships, as well as prevent healthy competition and prevent Medicaid from using the infrastructure that's already in place by the private sector and Medicare. Instead, we encourage you to examine the approach taken by Medicare and the private sector, and we're confident it could be improved and refined to meet Medicaid's needs. The use of separate geographic regions would limit potential savings by imposing geographic boundaries that match neither the provider groups found in the ACOs nor the patient groups they are serving. In the initial stages, most of these arrangements involve what's called a shared savings approach that entails a fee-for-service payment for specific services, plus incentive payment contingent on the ACO's achievement of agreed-upon quality measurements and overall cost for the assigned group of patients that is below projections. Simply stated, no savings, no incentive. Once the ACO gains some experience and skill in earning incentive payment, but also assumes some of the risk of costs exceeding projections. By considering a graduated approach to impose the risk on ACOs, a Medicaid program can ensure providers are prepared to assume the risk. In conclusion, it is important to consider that this approach to payment reform is being embraced by the private sector, by Medicare, primarily because they are facing the same challenges as our state Medicaid program, and the traditional managed care strategies of the past 30 years have not been successful. We appreciate the opportunity to speak with you today and stand ready to work as partners in strengthening our state's Medicaid program.